Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk. Thanks, everyone, and hopefully this will be an interesting and clinically relevant discussion, and I'm glad we will have cases today that will help you think about this topic. So I am really going to focus on long-acting injectable cabotegravir for individuals who are not ideal candidates, so individuals who miss doses of their ART or who have detectable viral loads or who may not be able to adhere to clinic visits or engage in care perfectly. I don't have any conflicts of interest or relationships to disclose. I'd like to acknowledge our funders. I'm going to do my best to avoid trade names. And I want to start with what's in the guidelines. And this was just updated last month, and I really want to be clear about what our national guidelines say. So the HHS panel recommends against use of long-acting ART, in particular, IM, CAB, and Rilpivirine in people who have detectable viral loads due to suboptimal adherence to ART and who have ongoing challenges with retention and care, except in a clinical trial. So this is what's in the guidelines. The guidelines panel thought about this and recommended against it. So why are we talking about it? So it still comes up. It still comes up in clinic. This came up in a clinical case discussion at Madison Clinic this morning. There are situations where this may be the only option and where this still may be considered. And there are two recent publications and some data that has gotten some press and really stimulated a lot of discussion and controversy around this. So I'd like to share that data with you, and I'd like to ask you to think through it and give your thoughts as well. And again, this may come up in clinic. So first, we've reviewed this before, but let's emphasize it. What is the FDA indication? So long-acting IM cabotegravir is considered a complete regimen for adults or adolescents, as specified there on the slide, to replace a current oral antiretroviral regimen in persons with stably suppressed viral loads, individuals who are taking a stable oral ART regimen with no history of treatment failure and no known or suspected resistance to cabotegravir or Rilpivirine. So that is the FDA indication. That is the way it was studied in large randomized controlled trials. I think you all know that the oral lead-in period is now considered optional. We've discussed that before. And there are a lot of considerations if you are discussing IM cabotegravir with a patient or client. There's whether you're doing every 1 month dosing or every 2 month dosing, both of which are approved. There's an initiation phase and then a continuation phase for either option. The doses are different depending on which option you are going to do. There are considerations around planned missed doses and unplanned missed doses, considerations around the site of injection, around the needle length, around the duration that the medication can stay at room temp. So there's a lot to consider here, and I'm not going to go into that. But we have slides and information covering all of those considerations on the National HIV curriculum. So I would look at that if you are trying to get a person started on this option. But I am really going to focus on this question, which I want you to consider and think about, and I want to hear your opinion. Should this option be considered for individuals who have significant challenges with oral ART adherence and or have detectable viral loads and who don't meet all of those FDA eligibility criteria that we just reviewed? I think you can imagine the benefits of this, of long-acting ART for someone who struggles to take pills or who struggles to get to their appointments. I think you can clearly, imagine how this could help reduce pill burden, pill fatigue, address concerns around stigma and disclosure, or a person may not have a safe place to store oral meds. I mean, we can all, I think, easily think about the benefits here. So then what are the risks and what are the concerns? And I think the biggest thing involves this being 2 drug therapies. This is not a full 3-drug regimen. It's 2 drugs. Neither of these drugs have as high a barrier to resistance as other options. And these are very long-acting drugs. And I just want to put this out there for thought. How long do these last in a person's system. So if we go to some of the Cabotegravir PrEP data, the Cabotegravir time from last injection to concentration below limit of detection on average was 44 weeks for individuals born male and 67 weeks for individuals born female. But look at the range. So an average of 67 weeks, but a range from 18 to 226. So that's 4 years that this may last at a low level in a person's system. So the concern comes from if a person receives these injections and then they miss doses or they fall out of care and they don't take ART, and then they develop rebound HIV viremia, these drugs may still be in the system at a low concentration, which is a setup for development of resistance. So pros and cons, and that's why this can be such a difficult decision. So I'm going to show you data from 2 studies, and I'd like to hear your opinion about this. So this study from the UCSF Ward 86 group has gotten a lot of press and attention. So I'm really going to focus on this and then turn to the compassionate use data. So the study setting here is a safety net clinic in San Francisco City and County. Their clinic serves over 2,400 adults with HIV, vast majority of whom have government insurance, so Medicare, Medicaid, or local drug assistance programs. 21% identify as Black, 27% as Hispanic. It's been estimated in the clinic that 15% have HIV viremia, 10% chronic viremia, and the group has shown that these individuals with chronic viremia do have higher rates of mental illness, stimulant use, and unstable housing. And the system there has a clinic called Pop-Up, which it seems to me to be very similar to the Max Clinic here at Madison and Harborview. So the focus is on individuals who have unstable housing and a lot of barriers to adherence. And they offer drop-in visits and a really extensive support network. And they have shown that development of the system has helped individuals achieve viral suppression. So we've talked about our Max Clinic before, and my impression is this is a similar model. But let me go through their protocol for considering individuals and initiating long-acting CAB Rilpivirine. And I think there are a lot of important points to take home here if you are considering this, especially for somebody who struggles with taking their pills or struggles with making their appointments. So they spent time educating all the providers in their clinic about this protocol. In the protocol, they did consider individuals with or without undetectable viral loads, so that makes it very unique from the randomized control trials that led to approval of these drugs. Individuals had to be willing to attend their injection visits, receive 2 injections in the glutes at each visit, resume oral ART if injections were interrupted, and had to be willing to give 2 contact methods, so a direct contact method for them and then a backup, a friend, a family member, a case manager. And then there was a review, and any Rilpivirine resistance mutations led to exclusion. One integrase mutation actually was allowed, and I think this is something we could debate, but prior studies have shown that a predictor of virologic failure on this regimen is really the Rilpivirine resistance and proviral Rilpivirine resistance, and integrase mutations haven't come out as much as a predictor. But again, I think we could debate this, but this was their protocol. Hep B was allowed if a person was willing to continue or start Hep B therapy, and they did favor a direct to inject method, meaning skipping the oral lead-in. If an individual was to start this option with viremia at baseline, then an individualized plan for adherence support was developed. This involved case managers, home and street-based nursing services, community injection sites, including harm reduction sites where injections could be delivered and blood could be drawn, as well as financial incentives for visits and for labs. The financial incentive was a $10 grocery voucher, and individuals had monthly checks of their viral load, their HIV RNA, and if at the second injection visit they remained viremic, a resistance test was performed. The clinicians also did a regular multidisciplinary review of patients who were receiving long-acting CAB Rilpivirine. This was an every 2-week review for all patients, or every 1 week for those involved in the pop-up program, the program to support unstably housed individuals. And everyone started with every 4-week dosing. So all individuals who receive injections started with every 4-week dosing. In their protocol, it said that individuals could switch to every 8-week dosing only after they documented viral suppression for at least 6 months, which is interesting. That's not in the package insert or guidelines in any way, but that was their protocol. Although reviewing the publication, it did not seem that anyone actually successfully switched to every 8-week dosing. Everyone reported in the publication, all the data I'm going to show you is from every 4-week dosing. So the first step in their protocol was a review by the pharmacy team, and then a visit with the pharmacist. So the pharmacy team was really integral to this approach. So the pharmacist would review eligibility based on looking for drug-drug interactions, past resistance tests, their hepatitis B status, and then if the individual is deemed eligible, they would have a visit with the pharmacist to talk about the injections, the protocol, what would be involved, the pros and cons, and then the pharmacy team really took charge of the drug authorization and procurement, and then a bilingual pharmacy member called all individuals within a week of their first injection, and then also was responsible for calling and texting for appointment reminders and for missed visits. Patients were instructed to keep 1 month of oral ART on hand in case of a missed injection by at least 7 days. Remember, with monthly dosing, the target date, the on-time dosing is 28 days plus or minus 7 days. So if somebody missed by more than 7 days, then there would be outreach. If an individual missed an injection by more than 10 days, then a viral load was checked and genotypes were performed to look for new resistance. If an individual had an unplanned misinjection, then there were attempts to contact them, there were in-person outreach efforts, and then they repeated the loading dose of the medication if the injection was missed by more than 42 days. And that's a little different than what's in the package insert, which is to repeat if more than 60 days have elapsed. So this is a little more conservative in that regard. Now, here are the individuals reported in this study. So overall, 132 were referred to consider long-acting cabotegravir. 51 started injections and 39 received at least 2 injections and are included in this report. One thing I would note here is that 51 started injections, but 39 are included here, and it's not clear to me from reading the manuscript whether these other 12 individuals who weren't included, whether they simply hadn't gotten to 2 injections yet or were waiting to start, or were doing well, or it's not clear to me what was going on with them, but they weren't included even though they had quote unquote started injection. So that's one question I was left with reading this. But then here is a description of the 39 individuals who did receive at least 2 injections. You can see the median age range. You can see that 35 or 90% were cisgender men, so only 4 were not cisgender men. There were 3 cisgender women and 1 transgender woman. You can see 21% identified as Black, 26% as Hispanic, a third as having unstable housing, and 8% or 3 individuals as being homeless. There was a relatively high rate of stimulant use at just over half. And then this, I think, is a remarkable thing, and I'll come back to this again on the next slide. So 15 of the 39 individuals started IM cabotegravir with a detectable viral load proximal to the first injection. You can see the mean viral load for those individuals who started with a detectable viral load was pretty high. The mean was 4.6 log. And then you can see the CD4 count for those who started an injection with detectable viral load. The median was quite low, whereas it was quite high for those who started with an undetectable viral load. And then they note that 5 patients were receiving other long-acting injectables. But really here what we have is 15 individuals who started long-acting cabotegravir with detectable viremia, and 24, so the other 39, who started with an undetectable viral load. So in the next slide, I'm going to break it down by those who started with an undetectable viral load and those who started with detectable viremia. So first here, let's look at these 24 individuals who started with an undetectable viral load. You can see in the next row that most received a direct to inject strategy or did not do the oral lead-in. The median number of injections was 6, and all 24 or 100% maintained virologic suppression. So as in the randomized clinical trials, those who started with an undetectable viral load tended to do well and maintained an undetectable viral load. And this is notable here because this is a cohort of individuals, again, with a high rate of unstable housing and of stimulant use and of other barriers to adherence. But now let's look at these 15 individuals who started with a detectable viral load. So you can see they all received a direct to inject strategy. The median number of injections was 6, and 12 or 80% achieved and maintained a suppressed viral load. So 12 out of 15. However, there are a couple things to note. The 3 who did not achieve a suppressed viral load were on their way. The paper notes that while they hadn't achieved a suppressed viral load, they had achieved a 2-log decline in viral load, and basically it was going that direction. And if you see the manuscript, there's a chart of all the viral load trajectories, which I did not recreate here. They also note that one participant who had a detectable viral load at baseline had this N155H integrase mutation, which is it's moderate cabotegravir resistance, and even that person achieved and maintained a suppressed viral load. They note that 2 individuals in the cohort, including that individual, had not had a suppressed viral load for over 10 years until receiving the Cabotegravir. So this all sounds, pretty positive for this relatively, complex cohort of individuals who have a lot of barriers to adherence and engagement. So I'll come to the concerns in a moment. I'll mention that overall, they noted high adherence. Most individuals had only on-time injections. There was one person who had 1 late injection and 2 people had 2 late injections, but none of those led to loss of virologic control. They noted that one person had some unplanned travel to their home country and resumed oral ART and did fine. And there were, and I think this is notable, 2 individuals who were homeless who received their injections at community sites, so not at the clinic. So through partnership with public health, these individuals received their injections and in some instances their lab draws as well through a harm reduction mobile van or a community clinic, again, partnering with street-based nursing services and public health. And overall, the therapy was very well tolerated. So the conclusion of the study was that this shows preliminary short-term effectiveness of every 4-week long-acting cabotegravir in individuals with or without viral suppression in this diverse urban clinic serving publicly insured patients with frequent housing instability and stimulant use. I've highlighted here preliminary short-term effectiveness. I think these limitations are really critical. It is an overall small cohort. The follow-up was less than 1 year, and it is a unique setting. They had a whole team working on insurance authorization. They noted that long-acting cabotegravir made it onto formularies for government insurance in California for their Medicaid and their ADAP much sooner than other states, and they may have had an easier time getting insurance authorization than in other states. They did extensive outreach, had the option for drop-in visits, for injections in the field. These are things that may not be recreatable in other places. And then I note that there are 12 patients that they say started injections and we don't have details yet. So I wonder what will happen with longer follow-up. I wonder if this is reproducible in other settings, and I wonder if in other settings, payers will cover the meds. And again, I want to know what you think. I'm going to go through one other study that I'm not going to spend as much time on, but I want to add to what we just discussed. So this is the compassionate use program for long-acting cabotegravir. So what is compassionate use? So compassionate use is when a provider appeals to the drug company for access to a medication before it is FDA approved and before it is available. So there really has to be a compelling reason. So basically you submit an application to the drug company, they review it, and then decide whether the patient will receive the medication before approval or not. The eligibility for the long-acting cabotegravir compassionate use was adults with HIV who needed parenteral ART due to psychological or physical condition, or if they had prolonged ART non-adherence with progressive HIV disease. And you can see here the list of the conditions of individuals who were included in this program. Individuals were ineligible if they had resistance to Cabotegravir, with the exception of the K103N. They had to have an established relationship with a provider and established adherence to visits. And they could not be eligible for one of the phase 3 randomized controlled trials. So what that means is that this was a more complex cohort of individuals than would be in the RCT, either because they had very advanced HIV or an OI, or they just absolutely could not be randomized to oral ART. Here is the cohort. You can see, as opposed to the last study, there was a higher proportion who were female at birth. There was a fair proportion who had acquired HIV perinatally and had a lifelong history and a lot of past regimens. You can see the median age was somewhat younger than the last study, the proportion with current AIDS diagnosis. And then again, they had a proportion of individuals who started with a detectable HIV RNA. Here they actually had 28 people who started long-acting Cabotegravir with a detectable viral load, and you can see the viral loads here. And for a lot of individuals, they were starting with a very high viral load. Unlike the last study, most individuals here did get an oral lead-in. Again, all received Q4 week dosing, and you can see the median follow-up there at the bottom, 10 months. So I'll just highlight a few results, and then again, I'll be asking you what you think about this. So of the 35 individuals included in this study, 22 or 63% maintained or achieved a suppressed viral load. Of those who had an undetectable viral load at entry, 86% or 6 out of 7 maintained a suppressed viral load, so most. So again, that's more similar to the randomized controlled trials. I would note that the 7th person here, the person who didn't maintain a suppressed viral load, it didn't because they had a blip to 55 and then switched to an oral darunavir-based therapy. So for the most part, people who had suppressed viral load at baseline did well here. Of those who started the study with a detectable viral load, though, only 57% achieved suppression. So this is a much lower rate. And then overall in the study, 7 individuals stopped because of incomplete suppression, including 1 who had a suppressed viral load at entry and 6 who had detectable viral loads at entry. And what I would note was the majority of these individuals who stopped due to incomplete virologic suppression did develop new resistance, either to rilpivirine or cabotegravir or both. So I would call this moderate success, but again, I'd like to know what you think. Is this 63% efficacy in a cohort with very complex HIV? Is that good news or is that bad news? Is that better than we would expect, or is that really going to give you pause and give you caution treating someone who doesn't fulfill all the eligibility criteria? Again, it was a small N. There was no comparator group. Follow-up less than a year. So I really want to know what you think about this. So again, I'll go back to the panel recommendation recommends against it, but I think there might be situations that come up in clinic where a person has advanced HIV and they're going to die without other therapy, and where we have to consider this for any number of reasons. And I'll end just by saying that the guidelines suggest only doing this through a clinical trial. The clinical trial is this one here called Latitude. It is enrolling people with challenges to oral ART adherence with detectable viral loads, but they are not going directly to long-acting Cabotegravir. They have to take oral ART for at least 3 months, and if they achieve a viral load below 200, then they are randomized to the long-acting ART or to standard of care oral ART. So it has been rather slow to enroll, but that is the trial that hopefully will give us some more insights into this. But I have definitely exhausted my time. I will stop there, and I would love to hear what you think. So happy to take questions or comments.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button, and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.